just want to congratulate Annalita and Lacey for helping, and Chuck for his, and Dr. Drobner. What a great cast of attendees. I went through the list. It's people from all around the world, all different backgrounds. And this is very, very exciting. I'm really very proud to be a part of this. I always enjoy speaking to this group. I want to emphasize, I think as all speakers do, you have my contact information. So anything you want to contact me, it might be a simple question. Don't be afraid to bother me. Just send me a note. Hey, I had a question about an egg or whatever it is. And I'll be very happy to go over it with you. Some of you might have some research ideas. If you want to throw some research ideas by me, that's okay too. You know, I'm always looking to help people there and collaborate and whatever I can do to help. So thank you for having me.
We have such need to love another, but we can't even touch each other. Sisters cannot see their brothers, children can't be with their mother. Our parents sit at night alone, all we can do is use the phone. Dad doesn't like to talk too long, it's never been his way. So we dream of how life used to be, to hold you close, to kiss your cheek, to feel that contact, feel real love. We miss the world the way it was, we miss being allowed to hug. Lovers push off wedding vows, the prom corsage, the cap and gowns. Little people carry the burden, a rich man keeps a cigar burning. Can't go in the house where we grew up, no more Sunday dinners. Instead we drop food off, we say hello and goodbye from the porch. They don't show that they're afraid. So we dream of how life used to be, to hold you close, to kiss your cheek, to feel that contact, feel real love. We miss the world the way it was, we miss being allowed to hug. Crowded restaurants, noisy bars, weekend flight for R&R. Bring us back our brightest Broadway stars. So we dream of how life used to be, to hold you close, to kiss your cheek, to feel that contact, feel real love. We miss the world the way it was, we miss being allowed to hug.
All right, so I think most of you figured out that was me. And there's actually some stories about that song. Some really are very sad. First of all, you see my hair is shorter in that clip. That was back in the day, that was in the peak of the pandemic, and you couldn't even get a haircut. So I cut my own hair. I cut my own hair twice during the pandemic. And it's kind of, you know, hair is a very personal thing, you know? And just the thought that you would have to cut your own hair, there's just no other option. I think that's a very powerful thing. I think that's really is. And then sadly, very sadly, the man who videotaped that recording for me and did the audio, I had just met putting that video together, and we became friends as we did it. And I learned a lot from him. And the very sad thing is he passed away from COVID. So very, very difficult, very difficult. But anyway, here we are. And I was telling Annalita that I did that song in like March, April, May during, what we thought was the peak of the pandemic. And I rushed kind of to get it out. I said, we better hurry because who knows, this COVID, maybe it'll just go away. And that didn't happen. It's still with us. That was over a year ago that I put that song out, and we're for some of the countries around the world, we're no better off than we were then. So that's really, I never would have thought that or predicted that. All right, so here we are. We're going to talk about women's, mostly, some about men, reproduction. And why is this important for you to know about the reproductive system? Why is it important to you to know about infertility? Why is it important for you to know about in vitro and the things that we do in the lab? Well, these are really very strong ethical issues for many people. And what I like to think about this course is that we're teaching you how to debate these issues. We're teaching you how to be advocates for people, whatever their problem is around the world related to bioethics. Because there are people on the other side who are fighting to prevent women and men from having rights, basically. So your job is to go out there and promote the rights of all of us. And you have to have some sort of educational background on reproduction, because you're going to be fighting for birth control. You're going to be fighting for an IUD. You're going to be fighting for a woman's right to do whatever she wants, right? So, because there are people who are going to counter you. So the way you're going to be stronger is you're going to have information. You're going to know. You're not going to just know what people told you. You're going to know what I tell you. And that'll be very, very important. So let me share my screen here. Now, I don't know about the format, but if anyone does want to, I guess the chat or any questions, you can just interrupt me, by talking or whatever, we have whatever, I'm not going to be upset, whatever you guys want to do. Okay. Or we can ask questions at the end, but really, I think the discussion is nice, right? So if you have any things to say, feel free. All right, so I represent NYU Langone Health. We're a very large institution. When I got to NYU in 1990, we were a very small institution. We were just, you could barely find us. There was a little awning, and now there are buildings everywhere. And so it's kind of nice to see the changes. Here's our beautiful entrance. These are some of our buildings. Here's one of our lobbies. People love to show this picture. It's kind of artistic. This building is a research building only. That's the only thing that happens in this building, and we have many other research facilities, but here's one. Here is our new hospital. This is all patient services that takes place here right along the East River. It's beautiful. It's state of the art. We have facilities in Brooklyn, which is something new over the last few years. So we've really expanded there. We have our own cancer center. So we're now over 6 million square feet of space, and we recently became involved with Long Island, a big hospital there, and who knows, maybe it's 8 million square feet now. So, right, a studio apartment in Manhattan is about 400, 500, 600 square feet, and NYU has 6 million square feet of space. Crazy. This is one of the photos of our fertility center. This is where we treat our patients. We're very, very busy, as you can imagine, and we're moving to a new space, a new women's center. This is going to be closer to Grand Central, and we'll have obstetrics, gynecology, and the fertility center will take up an entire floor in this building. All right, so what is infertility? The definition of infertility is no pregnancy after 12 months of trying if you're under the age of 35, And if you're older, then, you know, it's a shorter period of time because you need to get a workup sooner. This age distinction is crucial. You'll hear a lot in my talk about age and fertility. All right, so how long does it take for someone just trying to get pregnant? Well, after 6 months of trying, about 66% of women are, here's the line here, pregnant. And after 12 months, most people are pregnant, but there's still a good percentage that are not. So these are the people that we're focusing on. A woman's odds of getting pregnant are rather high when she first starts. Could be 20%, 30%, depending on how old she is. Could be lower if she's older. But every month a woman is not pregnant, her odds go down of getting pregnant in the following month. So after a year of trying, if a woman is not pregnant, her odds of getting pregnant in that 13th month are about 3% per try. Now, it's not because she's got that much older. It's not because she has, you know, done something wrong. It's just that maybe her odds were lowest to begin with. And now she's been trying and she puts herself into a category that, okay, now it's proven that she's having trouble conceiving. All right, so this is a graph. This shows fertility with age. And these are all people who were trying on their own. And you may be familiar or not with groups that were primarily in the United States, but also in Northern Germany and the Netherlands. These were religious sects that felt that they should have as many children as possible. So there was no like gap in between kids. No, there was no elective gap. It was all about just trying. So many of these women had 12 and 13 and 14 children. And before we had science about aging and reproduction, et cetera, this was just some data. People started looking at this first and they say, hey, what's going on here? Some of these women are trying to get pregnant as they age. They're having more trouble. And maybe today that's kind of very common thought, but back then it was like, oh, we never realized that. This was the first introduction into that. All right, so what controls ovulation? The brain, ovulation, right? The fact of getting an egg to develop, to ovulate, to be available for fertilization and to become a baby. That's what ovulation is. That's actually controlled by our ovaries. Obviously, that's where the egg comes from. But the control of it is our brains, So it's the cortex of our brain sends signals deeper down. Then there's our midbrain. And then the key element here is our pituitary gland. This is the gland which makes hormones which control men and women's fertility. So here's the brain, here's the pituitary gland, and the pituitary gland just doesn't control fertility, just doesn't control the ovaries. The pituitary gland sends signals to the thyroid gland, our thymus, our pancreas, our adrenal glands, in the case of men, their testicles, and ovaries in females. So the pituitary gland controls a lot of most of all of our hormonal systems, but we're going to focus just on the reproductive part. So I mentioned the word hormone. A hormone is a substance that's made in one place and travels to another place. So the pituitary gland makes a hormone that goes to the bloodstream, that goes to the ovary to get the ovary to do something. The estrogen that a woman produces goes to other parts of her body to get those organs to change, the breast, the uterus, et cetera. So here you go. The hormone that the pituitary makes is FSH, follicle stimulating hormone. That's kind of a nice name because it's easy to remember because the ovary makes follicles and that's what's ovulates. So follicle stimulating hormone. When a woman takes oral contraceptives, the way that prevents her from becoming pregnant is that it blocks this FSH production. Therefore, there is no ovulation, right? So that's how oral contraceptives works. They prevent ovulation by preventing signals from the brain being produced to contribute to the ovary for ovulation. So if anybody asks. All right, so ovulation, what happens during ovulation? Ovulation does two things. One thing, it gets an egg to, now I say here it produces an egg. We're not really producing an egg. The eggs are already there. We're not developing an egg. Women are born with their eggs, as I explained, and they don't make any more after birth. So what ovulation does is it gets an egg that's there and gets it to come out, gets it to ovulate. So that's one thing ovulation is. But then there are also side effects of that in hormone production. So we get estrogen. The ovary also releases an egg, but it also produces these hormones which are necessary, estrogen and progesterone, among others. All right, so this estrogen, this is a picture of a uterus. It's a drawing. I know a lot of you aren't medical. I'm going to say this a few times during this talk. Try not to look away when I show you pictures. I'm going to show you some videos. I'm going to show you some photos of human organs, the uterus, the ovary. A lot of people get turned off by those things. They're like, oh, I don't know what I'm looking at. I don't want to see that. But to me, it's all I want to do all day, right? It's great. But try to stick with it, because the problem with looking at pictures or looking at photos is there's a lot going on, and it's very hard if you don't know if you're not familiar with it, to kind of focus on the key parts. So I'm going to do that. I'm going to help you. I'm going to say, look, forget about everything you're seeing. Let's just focus on this one little thing, and we'll get through it together. All right. So this is just a drawing. Drawings aren't always that accurate and everything, but this is not a bad picture. So this is a picture of what a uterus looks like. And so what happens when I talk about hormonal production, estrogen, as the egg is getting ready to ovulate, these hormones that are being produced are affecting the uterus, because that has to be prepared for the embryo to stick. So the way it prepares it is it gets the lining to increase, to get thicker, because this way it's a nice sponge for the embryo to stick. So estrogen makes the lining thicker. Okay, this is an ultrasound. So there's a lot going on here. There's numbers, there's names. This is where we're going to focus on. This is an ultrasound, and it looks very different. I get that, but it's a view of the uterus. It's just a muscle. This is a uterus. These are the borders. Here's another uterus. These are the borders, and you can see the difference on the inside. This is the lining. This is the muscle. This is the sponge. Here's the sponge. See how the sponge is thin here? See, you can see how nice and thick it gets here, thicker. That's what estrogen is doing. It's getting that liner thicker. Now, there are two main hormones of ovulation. I mentioned the estrogen. That's getting the lining thicker. But then the progesterone, you need to have progesterone for the embryo to actually stick and grow. You may be familiar with this RU46. This is a hormone which prevents pregnancy. And the way it prevents pregnancy, it blocks progesterone. If there's no progesterone, there ain't no pregnancy. It's impossible. But in a natural cycle, a woman has regular cycles. She makes estrogen in the first half, a little bit of estrogen, but mostly progesterone in the second half. And that's what allows the pregnancy to stick. If there's no pregnancy, there's other hormones that the body recognizes, because the pregnancy makes a hormone that will tell the body, hey, you're pregnant, don't make any changes. And if it's not there, then you have a period. On oral contraceptives, there is none of that. There's no estrogen, progesterone. Yes, those hormones are present in the pill, but they don't allow for the body to do its natural thing. So it's all flat. There's no changes. There's no estrogen in the beginning, progesterone in the beginning. It's just nothing comes from pituitary, and there's no pregnancy. Okay, intrauterine device. There's lots of ethical issues associated with the intrauterine device. Okay, it's something foreign that goes into a woman's body. There are a lot of groups out there who feel that this is a violation, that you shouldn't allow a woman to put something in her body for contraception or not. Once you add contraception onto there, then you're really elevating the discussion. There are some people who feel it's harmful. There are some people there's a lot of like mistrust of the medical system in certain populations. An IUD has a terrible, well-deserved terrible reputation because there was a very specific type of IUD that was medically improper. And what happened with that IUD is it led to infection in women. So we would put the IUD in, the women would have the IUD in, they would get an infection, a very, very bad infection, an infection that was so bad that in many cases, women needed to have surgery to have their uterus removed, sometimes even their ovaries. So that sounds absolutely horrible, right? But there was a big scandal because of course the drug company knew about it, but it didn't get fixed for a number of years and a lot of women were harmed. So the IUD how can you have a good IUD, a bad IUD, and then have a good IUD, right? That's how people think. So that's very understandable. But today's IUDs are very, very, very safe. The thing about the beauty of an IUD is that it's once you put it in, it can last for years and years and years and years. Women don't have to take the pill every time. They don't have to lose, if they lose their prescription, if they don't have access to their next prescription, that's a really big deal. The problem with an IUD really in the United States, at least, is it's rather expensive to get put in. Not every insurance covers it. And so that's a big deal. You know, I've heard lecturers talk about India and they like an IUD here might be $900 and then it may be $500 to put it in. I mean, that's a lot of money for a lot of people. In India, you can find an IUD for $3 and put it in. The problem there is there aren't enough people to put them all in. But an IUD is an amazing, fantastic form of contraception. What it doesn't do, it does not protect against sexually transmitted diseases. It does not protect, nor does oral contraceptives, right? So same thing there. The barrier contraception is still important, i.e. a condom, but it does not protect against HIV and hepatitis and chlamydia and gonorrhea, et cetera. And you've seen this picture before. Now you're getting used to it. Come on, stick with me. Here's the uterus. This picture is a little different because it shows the tubes and the ovaries. But that's it. You put the IUD in there and it prevents pregnancy. It doesn't affect the pituitary or anything like that. It's all local. It all prevents pregnancy local by altering the lining of the uterus. So fertilization doesn't take place and implantation does not take place. All right. Now, what are the most common causes of infertility? Well, you have some women don't ovulate well or don't ovulate at all. That's one thing. Some, we're going to talk about all these. Tubal disease. Some women, their fallopian tubes are not open. The tube is just a pipe. And through that pipe has to go sperm and an egg has to go through. And some people have problems with their tubes. A lot of women have fibroids. I'll describe fibroids. Fibroids are tumors of the ovary, of the uterus. They're benign. They're not cancer, but they interfere with the shape of the uterus and can interfere with the pregnancy initiating. Endometriosis. This is a cause for infertility also. That leads to scar tissue, tubal disease, a reduction in egg number. We'll talk about that a little bit. And age is really a big one. I didn't say it enough. Okay, so who doesn't ovulate well? So some women are just born with, instead of getting a period every month, some women get a period every 6 weeks or 8 weeks or 10 weeks or 12 weeks or never in a year. And so our job is to try to figure out why that's happening and to fix them. Now, women with eating disorders, anorexia, you remember that picture of the brain. In women who have an eating disorder, their calorie intake is so low, we don't completely understand it, but the brain says, wait a minute, this woman is starving. It's not a good time to get pregnant. Otherwise, we'll both be in trouble, the body and the baby. So there's some sort of internal mechanism to prevent pregnancy when a woman just has an extremely low caloric intake. Also in a famine, right? In a famine, women are not going to be able to reproduce if they're severely restricted in a diet-wise. And severe exercise can mimic that also. Kind of the cutoff is about 20 miles a week. So if a woman does exercise, some sort of exercise, that equivocates to about 20 miles of running per week, she may start to lose her period. Not everybody does, but many people do, especially once you start getting into 30 and 40 miles a week, which I know sounds like quite a bit, but ovulation is just not going to happen. There are disorders of the thyroid gland, which can prevent ovulation, and other hormones from the pituitary gland. So we measure those things. And then there's something called polycystic ovaries. In that case, those women don't ovulate either. Those women have kind of two problems. One is not bad, one is bigger. One problem is they don't ovulate. The second problem is they have a lot of eggs, which really is not a problem. If any one of you have polycystic ovaries or know of people with polycystic ovaries, I always tell people, if you're going to have a problem, that's the best one to have, because it means you have a lot of eggs, but you're just not getting one to come out every month. That's a very easy fix with medication, and we'll talk about that. All right, so say someone comes into my office, they say, look, I'm not getting pregnant, what do I do? I say, so I get a history, medical history, I find out when they're ovulating, the whole story, but believe it or not, there are some people who just are not trying. They just don't know how to try, which is usually not the case. They just don't want to try, which is more the case. You know, a lot of women, men, whatever, they have issues with the sexual encounter, and we have counselors to guide them through that and to help them. For a lot of people, it's about timing. You know, just like I said, ovulation takes place in the middle of the cycle. That egg's got to pop out. That egg's only good for about a day. So you have to have intercourse around the time of ovulation. You know, there's some rumors out there that you ovulate 5 days after your period. Well, that's not true. That's usually people ovulate about day 14. So if you have intercourse too early, you're going to miss the window. If you have intercourse too late, you miss the window. And we have ways to help them. There's kits that you can get in the pharmacy to help you determine the right time. But timing is important. These are the basic things. All right, so let's say the timing is okay and the history is okay. What do we look for? There's some tests that we do. So there's tests of, we want to see how many eggs they have. We want to make sure the anatomy is good. The tubes are open. We want to make sure the sperm is there. So let's go through that a little bit. We're going to learn more about anatomy. First thing we're going to talk about is egg reserve. How many eggs does a woman have? So the egg number decreases as a woman ages. Women are born with about 2 million eggs. By the time they hit puberty, before they've had one ovulation, they have 500,000 eggs left. So between birth and puberty, they have lost 3/4 of their egg supply, doing nothing, walking around in diapers, drinking milk out of a bottle, playing in the sand, whatever kids do, they're losing eggs all the time. Then by the time between puberty and menopause, which is about age 52, menopause is the loss of eggs, complete loss of eggs. A woman loses those 500,000, but the math doesn't make sense, because if a woman has regular periods and ovulates every month for 40 years, she'll go through about 500 eggs. So how do you go from losing 500 eggs to losing 500,000 eggs? That just doesn't make sense. Well, it makes sense because eggs are wasting all the time. Even when a woman is on a birth control pill, right? She's preventing that monthly ovulation, but she's still losing eggs, even if she's on the pill, even if she's pregnant, eggs are losing. So the one thing about this scale, it doesn't look so bad because this is a logarithmic scale. If you look at a regular scale, this is the egg count over time by age. So look, this is birth. Even by age 20, most of the eggs are lost. Now, luckily, there's a lot left over still, even though most are lost. There's a lot here between age 20 and 40, but you can see there's a big decrease between that time period. And another thing which we'll emphasize is that even though there are a lot of eggs here, as a woman ages, her eggs get worse. The quality diminishes. I'm very sorry for those. I always feel bad telling this, but it's true. Eggs provide the genetic component for us to be born, and that genetic component gets worse, gets more altered as a woman's age. So she might ovulate, but that egg might be genetically abnormal, more likely to be. And that's another reason why women lose their ability to become pregnant as they age. So it's two things. It's egg number, and it's the quality of the egg. Both are diminishing. And it's actually more about the quality than the number. Okay, so just like I just went through this, okay, the math. So we can assess the number of eggs that are there by measuring a hormone called AMH. It's just a hormone. It comes from the ovaries. This is a slide. This is an egg. This is an egg. This is an egg. This is an egg, 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 egg. And eggs have, in some of the cases, they're surrounded by these cells that make AMH. So the more eggs you have, the more of these cells you have, and the higher your AMH level. So we measure it. Okay, that's kind of hormones and eggs. We'll talk more about them. Let's talk about anatomy, just the physical plumbing. So we saw a uterus. We saw this already. This is where it sits in a woman's body: uterus, tubes, ovaries, and cervix. Okay. So an egg, when it ovulates, comes out here. And they always show these pictures where the tube is like right up against the ovary, where you think the egg pops out into the tube and then gets into the uterus. But it's really not that way. I'll show you some pictures. The tube opening is a little far away from the ovary. And the ovulation comes out, and somehow it doesn't go right in. Somehow the egg floats around and finds a way then to get into the tube. And then it gets fertilized in the tube. This is where fertilization takes place. And then after fertilization, this embryo wanders down into the uterus. Okay, so here's a photo. Okay, no one cringe. Okay, I'm telling you, this is stuff I love. I was born to be a doctor. I love this stuff, but I know some of you don't. I'm going to take you through it. This is a laparoscopy. This is looking through a woman's belly button inside her body with some gas. We pump a little gas inside so we can see it. It spreads it out. And this is a beautiful, beautiful picture. This is a uterus, those drawings I showed you, right? This is a tube. I know it doesn't look like much, but it's coming. The end of the tube is here. It's really not easy to see. I have some others, but the ovary is here. So you see, if the egg pops out of here, it has to kind of travel a little bit to get into the tube. And these are intestines. They're all there. Normally, actually, they're right on top of everything. Everything's kind of mixed together. But because the woman's head is down and we're pushing everything away and we have the gas inside her belly, pushing everything open, it makes it easier to see. So uterus, tube, ovary. Simple enough, I hope. Here's a nicer picture of the opening of, here's the ovary, opening of the tube. Again, it's not very distinct, but it's like the cuff of a shirt. It kind of opens up, and in here is the center. And this is where the egg's going to get in. It's going to travel in. It's going to cause and get fertilized in the tube. So let's just take a quick look here. I'm not going to spend too much time on this, but motion is always easier than still pictures. So let's see if we can get this to open up. All right, so here's this uterus that I talked about. Here's the intestines. You see they're closer here. Here's the ovary. Here's an instrument going in. And we're not going to watch the whole video, but I just want to show you what things look. This is actually the tube here. This is all the tube here. So doctors, this is another, don't worry about what he's showing you now or she's showing you now, but in a sec, we'll show you what we're looking at. So he's going to push, this is the tube. And that's where this is the intestine again. And we're not at the end yet. The doctor's just kind of pushing everything away. And again, it's not very distinct, but the end of the tube is in here. And here's the ovary. So that's kind of what it's very, notice how it's easy to move around. It's not attached to anything. We call it, it's free. I'm going to show you some pictures of cases where it's not free, where there's been some scar tissue leading to infertility. This is not an infertile picture. This is a beautiful, fertile picture. Looks really, really nice. Let's see if I do this. We'll get rid of this. And we'll go back to this. Okay. We have a few other videos. Stick with me. All right. So listen, we need to see if the tube is open. We need to see if it's that pretty picture. But we don't want to operate on everybody, right? We know that surgery you just saw requires full anesthesia, sharp instruments that go into the abdomen. If we need to do it, we do it. But we have an X-ray test that we can use instead that tells us a lot about the anatomy. So we saw this picture already. So we squirt dye into the uterus. It comes out the tubes and we see it. So this is what that looks like. This is the bones of the pelvis. This is dye now that's in the uterus, right? There's no colors. Sorry. Sorry. This is dye that's come out of the tubes. And then here are the tubes at the end. They're a little squiggly. They don't always look the same. This side looks different than this side, but this is dye that's coming out. Here's just another picture. It's a little bit different. This is all dye that's coming out the tube. So we don't have to do the laparoscopy and everything. We just do this dye test and it tells us. We find out a lot about people. Look at this. It's a little different, right? This woman happens to have either two uteruses or a division here between the two uteruses. So we find out a lot of things on this test. These are very rare. I don't want anyone to worry out there that they have this problem. This tube is kind of blocked, right? You don't see the dye coming out easily. All right, so I'll show you video of this. Videos are just so much better.
The hysteroscope test of the uterus and fallopian tubes. The physician will use a catheter to inject contrast agent, which shows up on
See,
X-ray.
we just put some dye in like you see, but this is like the picture you saw, but you see how it's really happening.
Cavity has
Putting the dye in.
triangular shape. There should be no areas
and now it's starting to come out the tubes here, see here? And again, they're different, a little different.
Tubes will begin to fill on each side.
And the end of the tube is about here, and now the rest of this is the end of the tube, and this dye is just pouring right out.
Will fill through.
So just pouring right out of the tube. Now you're expert on that, so that's good. All right, see these big swollen tubes? This is not what we saw, right? See how they're stuck? They're not free, they're not fixed. This webbing here is scar tissue. This woman has probably had, sorry about that. What causes tubes like that? Chlamydia, gonorrhea. These are prevalent throughout the world. And these are things that can cause a severe tubal blockage. Now, if someone has a mild case of chlamydia, it's very common. There's no fever, there's no pain, it's picked up, it's treated. Usually you're not going to get in that situation. But those tubes are blocked. Remember we talked about the egg kind of getting into the tube. Those tubes are, the egg cannot penetrate that scarred, blocked tube. That's why that woman, and this is normal again, is not going to get pregnant. Endometriosis. So what's endometriosis? So when a woman gets her period, blood comes out of the vagina. We all understand that, comes out the cervix into the vagina. But what also happens is some blood goes out the tubes. And in this blood, it's not just blood. It's this lining, this thick glandular lining that's been growing as a result of the estrogen. So what happens is there are some glands, some remnants of this endometrial lining that go into the area around the ovaries and the tubes, et cetera, and it sticks. Now, a lot of women have blood coming out the tubes, but those glands don't stick. But for some people, we don't understand why those glands stick, and they continue to grow and they cause scar tissue and problems. So this is what it can look like, these spots. This can be very painful for many women, and it can cause a lot of scar tissue. Here's, right, we just saw what a nice uterus looked like. This is and this is a lot of scar tissue here caused by endometriosis. This woman cannot get pregnant. The egg cannot find its way from the ovary into the tube. Again, normal. All right, fibroids. Shift gears. Fibroids are another cause of infertility. About 30% of women have fibroids. They come from abnormal cells. They are growths. They are growths inside the uterus. They are not cancerous. They can be very, very rarely, but almost all of them, they're just there. They're more common in Black women, but many white women have them. Most do not cause infertility, but many of them do. So here's a fibroid. This is a drawing. Here's a fibroid. Here's a fibroid. This is not going to cause infertility. This is not going to cause infertility. But when you have a fibroid like this, that's growing inside the uterus, this can cause infertility. Remember, I showed you the IUD. Something that's in there is going to interfere with an embryo sticking, an embryo growing. And this is going to cause a lot of bleeding. Here's a fibroid that's small. Normally, this size is not a big deal. But if it's growing very near or very in the cavity, like this one is, same thing. Pregnancy just is not going to occur. We have surgical procedures to remove these easily. Here's a fibroid, just a drawing of pushing. So the uterine, this is where the baby needs to grow. It's pushing in there. And this could cause infertility or also miscarriage. I mean, they're kind of in the same category, right? They both lead to a woman ultimately not having a baby. But fibroids can cause these problems. Millions and millions and millions of dollars a year are spent on fibroids in the United States and around the world, treating them, removing them, making them smaller, reducing the bleeding, hospitalizations, etc. It's not just a fertility problem. For many women with fibroids, there's a bleeding issue. Maybe a woman's done with her childbearing, but she's having significant bleeding such that she is anemic and needs a blood transfusion, etc. All right, we're going to shift gears a little bit more, and we're going to talk about sperm. So sperm has a kind of an anatomy, right? It's got a head, a mid-piece of tail. This swimmer swims right through. We count sperm. We want to make sure the sperm count is high enough. It's not enough just to have some sperm. I know. We all say it only takes one, right? Just takes one. But it's not really true. A man with a sperm count of 1 will never get a woman pregnant. You need to have millions and millions of sperm to just fertilize 1 egg. And I'll explain a little bit about that, but that's the issue. So we want to count. We want to see what a normal count is. So let's watch some swimming sperm. Let's see if this ignites. If it doesn't, that's okay too. All right.
If you're trying to lose fat,
sorry.
stop doing cardio. This sounds backwards, right? Well,
all right, so this is sperm in a dish. And we're looking at it. These are millions of sperm, and you see them swimming, right? And now we're gonna get a little up close here. This is a higher magnification. Now you can see them a little bit more individually, right? And you just see, again, for some reason, you need to have this quantity of sperm to fertilize an egg. You just can't have one that's running across the dish looking for an egg. Here's a bigger magnification. You can see them a little bit more closely. Here's one, right? There's some are blurry because they're in different planes, so you just can't see them on the microscope, but here they are. All right, so I think we get the idea there. Okay. Now, pregnancy is related to sperm count to a degree, right? If the sperm count is very low, the probability of conception is low. And as sperm count increases, the probability of conception increases. But once it gets to a certain, 50 million, 40 million, maybe 30 million sperm per cc, then the fertility rate is the same because it is true, you need a lot, but you only need so many. So if the sperm count is 100 million or 50 million, it doesn't matter. Pregnancy rate's the same. It's only when we get into these lower levels when we need to help a man conceive. Okay. Causes of low sperm count could be genetic, chromosomal defects. It's a small percentage, could be something. Infectious, maybe there was a bacterial infection that caused the low sperm count. Could be congenital. Maybe there's a piece of the tract missing, right? The sperm has to travel from the testicle to outside of the penis. So it has to, there's pathway. And if the pathway is blocked, then there's not going to be any pregnancy. And then there are hormonal issues, just like in women, there can be hormonal issues. Remember this FSH that I mentioned stimulates egg production, egg release. Well, FSH and LH hormones also go to the testicle to make sperm. It's interesting, same hormone. And some men through pituitary problems or thyroid problems or whatever it is, they don't have the hormones necessary and their sperm counts will be very low or absent. All right, so that's kind of a background, all right, on anatomy, on why some people don't get pregnant. a little bit about the sperm, and we're going to talk a little bit about the treatment now. So let me just see here. Guys, is it okay if we take a 5-minute break? All right, so it's 11:27. Why don't we come back on at, if it's okay, 10:35? Is that okay with everybody? New York time? So 7 minutes?
Sounds great.
Okay, I'll be on. I'm just gonna turn my camera off, and I'll be back at 10:35 New York time. Time. All right, so now we're going to talk about, okay, now we've identified a problem or not, just to say that in many cases, we do not identify a problem. We check the sperm, we check the tubes, we check the hormones, everything is fine. So that goes into the category of unexplained infertility. And we continue to treat them. We don't have to fix the tube, we don't have to fix the sperm count, but we go on with some sort of method of treatment because again, if after 6 or 12 months of trying, there's a problem, even if we don't find anything, we need to do something. So what do? One of the things we do is insemination, intrauterine insemination. What does that mean? We get a sperm sample, we process it. We get out the dead sperm and the debris, and then we place a more pure sample inside the uterus. Why do we do that? We do that because only 1% of the sperm make it from the vagina to the uterus. And then from there, only 1% make it to the tube. So here's just to give you an idea, this is what we end up with starting with all of these. So from the vagina to the uterus, from the uterus to the tube. So now the system really can't be that terrible, right? Because most people get pregnant rather easily. Most people do. So whatever diminished return is happening seems to work for most people, but when we're having trouble, we try to overcome these barriers. Insemination itself only adds a few points onto the chance of a woman becoming pregnant. So if let's say she's been trying for a year, her odds are 3%. If you do insemination, maybe you're at 5%. Not that different, but it's a little bit better than trying on your own. And what we'll do is sometimes we add medication on top of that to help improve ovulation. And maybe her odds are 8%. So 8% are better than 3%. And because it's relatively easy, right, compared to doing in vitro, we do a fair amount of insemination, although we're doing less and less insemination all the time. More and more people are going to in vitro sooner. More insurance companies are covering it. That has a lot to do with it. And a lot of people they're waiting longer. They don't like the idea of having a 5 to 8% chance per month of getting pregnant. They don't like that. They want to hear that their odds are maybe 30% or 40% or 50% or 60%, whatever it is with in vitro. So, but still, we do a fair amount of IUI. We use fertility drugs. There's different types. There's pills and there's shots. The pills are easier, obviously, right? You may have heard of Clomid. You may have heard of letrozole. These are pills women can take that can help them ovulate. And then there are injection, and these are hormones, FSH and LH, same hormones that are in our body. It's just a higher dose. Now, these are hormones. We didn't really talk about we talk a lot about hormones, but just to define a hormone a little bit, right? I said already, it's a substance that's made in one place that goes to another. And the other important thing, amazing things about hormones is that they land in a landing spot on the cell. It's called a receptor. So this hormone, it lands on a receptor, it locks into that receptor, and then the receptor gets the cells to change, to get thicker, more mucus, whatever it is. But we can use this receptor phenomenon to our benefit also. I'll take you a little bit through this. So this has a little bit to do with fertility, but it also has to do with a lot of just hormonal treatment in general for fertile conditions or other medical issues. So it's all about the shape. So go back here, see how this shape matches this. This is lock and key. This shape is crucial to the functioning of a hormone. If the shape is just a little bit off, the hormone might not work at all, even if it's slightly off. Or if it's slightly off, it might work a little bit. Or if it's slightly off, actually, a drug might work better than the hormone that's in our bodies, all based on a little bit slight shape difference. So these are two molecules. Don't worry about the colors. They're just drawings. But the point is that these are two very, very similar molecules. But, you know, this pink part here is a little bit shorter than this one. See how this blue part is bent and this part is bent down. These subtle, subtle things can make all the difference in the world on how a hormone actually, or a drug, functions. So when we talk about a fertility drug like Clomid, what Clomid does, believe it or not, it sounds weird, it blocks estrogen. So how can you get pregnant from a hormone that's blocking estrogen? Because it doesn't block all of it. And what it does, it blocks a lot of it in the brain. So a woman takes a Clomid pill, it blocks estrogen, and the brain says, oh, there's no estrogen, let's make some more. So it puts out more FSH to drive the hormones to work better. So just to show you, this is the estrogen hormone, has a certain shape. Now the problem is I'm showing you a two-dimensional shape. It's really the three-dimensional shape that's very important. And this part, if you use your imagination, this part of Clomid or clomiphene is shaped a little bit like estrogen, a little bit, not a lot, but a little bit, but enough so that when it gets to that receptor, it can land on that receptor, lock in, and not let estrogen, anything else bind there. Tamoxifen, maybe you're familiar with tamoxifen. It's given to treat breast cancer. Very important drug. If a woman takes tamoxifen, her chances of having a recurrence with breast cancer is reduced by 50%. That's a huge difference. Same thing. This tamoxifen looks a little bit like estrogen, not so much, but it goes to the estrogen receptor and it sits there, and it doesn't let estrogen go there. And estrogen is one of the causative agents in breast cancer. So if you can block that, you can reduce breast cancer. And again, it doesn't look the same in a 2D, but in a 3D, it would look the same. In any event, they're similar. I explained how this works, right? So here's your FSH coming from the pituitary. Clomid is going to increase this hormonal production. Now, these drugs, these oral drugs, are amazing for women who do not ovulate. A patient who gets their period every 80 days or 180 days, whatever it is, most of the time, she takes a pill, she's getting a period every month. And once she starts doing that, then her pregnancy rates goes way up. Now, a lot of our patients don't have that problem. A lot of our patients are getting regular periods. And for them, the pregnancy rate increases a little bit, but not as much, because you're not fixing as big of a problem, but we still use a lot of these medicines. Okay, so those are the pills, letrozole and Clomid. We give hormones that have to be given by injection. The reason we can't give those by mouth is because the stomach acid breaks them down. They have to be given by injection. So follicle stimulating hormone, we've heard it 10 times today, same hormone our body makes, but a bigger dose. And it's made in large quantities. It used to be extracted from urine. Now we actually make it in the lab from these Chinese hamster cells. And there's actually, I've been reading, there are some human cells that we're now trying to use to make this FSH, but it's all made in a very complicated laboratory situation. All right, so the reason we use injections as opposed to the pills is the injections are stronger. For some people who don't respond to the pills, we have to give shots. If we want to get more eggs, we use shots. They're absolutely more powerful. All right. Now this is a bioethical conference. Let's take a diversion. Let's talk about ethics. We're going to talk about ethics at the end a little bit more too, but let's talk about it now. So you would say, what could possibly be the bioethical consequences of infertility, right? How could that, a woman's not getting pregnant? What are the ethics there, right? Well, even forgetting about infertility treatments, whether you think in vitro is ethical, just having infertility, just not being able to get pregnant in many societies is a colossal problem. Colossal, right? So what are the effects of infertility? Well, just psychologically on the woman or man, couple, distress, raised anxiety and depression levels. Like the people of the world are depressed enough. They have enough anxiety. Now you add fertility onto this, it's really a big deal. Lower self-esteem. A woman's not getting pregnant. What does she say to herself? There must be something matter with me. I must have done something wrong. I'm a bad person. I'm a bad mother. I'm bad. People say that. And, you try to talk them out of it and the whole thing, and counseling's great, but still deep inside, these are thoughts that people have, right? Feelings about blame and guilt, somatic complaints. I mean, this goes along with any sort of anxiety and depression, but if fertility is going to increase that, then they might have perceived medical problems. They might get tummy aches. They might get headaches. They might get sleeplessness. This is all related to not being able to get pregnant. And reduce sexual interest, right? You just become depressed. Maybe you just figure it's not working, and then your odds of getting pregnant are even lower. Maybe there's pressure. All of a sudden, you think about sex in a different way. You think of more about it instead of it being a natural thing. You start thinking of it as a performance thing. You start thinking of it as a thing like, oh my God, I'm going to get graded on this. I'm going to have an outcome that I have to worry about. So that's a very important thing. It's very difficult for an infertile woman to go to a birthday party, other social gatherings. There's lots of questions from people all the time. Hey, when are you going to start having kids? Especially from the parents. They can be the biggest offenders, but they might be harmless. They just want to have grandkids. They don't realize maybe that a woman's not getting pregnant. What happens is when it's time for a woman to get pregnant, it's the same time for her friends to get pregnant, right? People her age. So she's trying to get pregnant. Guess what? Her college roommate's trying to get pregnant too, or the girl she grew up with, she's trying to get pregnant too. And guess what? They're getting pregnant. So all of a sudden, the girl she grew up with, the girl she went to college with, they're all getting pregnant, and she's not. So that's real. Her cousins who are her same age, they're getting pregnant, and she's not. That's very, very distressing. So the global issues are, for many communities, there are rules related to becoming pregnant. There are economic factors that go into pregnancy. There's discrimination from the in-laws. There are actual legal issues in certain societies saying that you're in a marriage, you have to have a baby, at least one or two or three, or a son at least. So there are marriages that just break up because the husband may love the wife may love the husband, but their community is not buying it. They don't see a baby, they're not going to stand for it. And this is a real thing. There are spiritual problems, right? A woman's not getting pregnant. Maybe her spiritual leader disavows her, shuns her. The spiritual community doesn't allow her in, isolates her, or both of them. Usually it's her, obviously. So that's a real problem. What happens to that woman who's not getting pregnant? She has economic hardship. She may not have the support of her husband. She may not have the support of her family anymore, the community support. She's isolated economically, socially. There may be violence against her. She might get raped. She might get just punished. And if she does die alone, she may not be permitted to have the normal burial rite that goes on within her society because of the fact that she was never fruitful, never bore children. So in certain societies, it is important for women to demonstrate their fertility within 1 year of marriage, right? Who takes care of the in-laws? The son's wife. And if there is not even, forgetting about fertility, if a son is not born, then it's going to be a lonely life for the elders because no son, no son's wife, no taking care of the kid, of the older people. The family name may not go on. And again, to us in a modern Western society, like these things maybe not aren't important to us, but the rest of the world, that's why we're here today. The rest of the world is not a Western modern society. Literally a different world out there. So these are things that we have to know about. And our immigrants who come here, we have to understand these things. There may be lack of pension, no financial support without children, and many women are powerless. Even the one with children, many women are powerless. And women without children are even worse off. So here's a graph, some of the things we talked about already. There's stigma. This woman is not pregnant, therefore she has a stigma on her. There's marital problems. There's literally harassment by in-laws. There's public ridicule, status loss, isolation, no economic security, divorce. The husband might take on an extra wife. Or they might send the wife to the husband's brother to try to get pregnant, or somewhere else, which I have a quick slide on that. There might be witchcraft, voodoo, other issues that come into play. Exploitation, the evil eye, and illness that women may not be able to get treated for her illness. HIV, this happens. A woman may be sent somewhere else to get pregnant. Who knows where? Who knows by who? And this could be a significant problem. All right, so that's a little bit about bioethics. We're going to come back to learning more about how this whole thing works. We're going to talk about in vitro. All right, so the way in vitro fertilization works, it's 2 weeks. It's a 1 or 2 month process, really. But the first 2 weeks are just getting the eggs, harvesting the eggs, getting eggs in the lab. And that requires 2 weeks of injections of hormones. Now you can do it without taking drugs. You can do an IVF cycle, just follow the natural ovulation. And just before that egg's about to ovulate, we grab it. But that's very inefficient. We can't get the egg every time. We still have to do the same thing. We still have to monitor that woman. We still have to make sure everything's okay. We still have to use the needle to get the egg. So it makes much, much, much more sense to try to get as many eggs as we can at one time. So it's 2 weeks of injected hormones. It's 6 or 7 office visits. There's a retrieval, which means getting the eggs. I'll show you that. Then we fertilize the eggs. I'll show you that. Then we grow the embryos. I'll show you that. And we put the embryos in. I'll show you that. So this is an ultrasound. This is an ovary. Again, I'm sure you're not used to looking at this, but here are the boundaries of the ovary. All of this other stuff, don't worry about it. It's intestines, blood vessels, muscle, but here's an ovary. And here, these little dark areas, these are areas where eggs are. These are the follicles. And you see you got a big one here. So this is just before ovulation. This could be like 20 millimeters, not an inch in size. And it's going to pop and the egg is going to come out. Okay. And these might ovulate next month or the month after. So when a woman starts in vitro on the second day of her period, she's nowhere near ovulation, obviously. And her ovaries kind of look this way, just quiet. This is the ovary. Here's the follicles. They're all small. And then they start to get bigger from the drug. So a few days later, now we see these follicles again, they're starting to get a little bit bigger. And now they're bigger, okay? This is, again, as a result of taking the drug. And what this is during in vitro, you see the needle going into the ovary. I'm going to show you a video of that. I think that's next. So here's a drawing. Here's the uterus. So in this drawing, the tubes are blocked, kind of those big tubes I showed you. Here's the ovary, here's the vagina. So we just bypass, we don't deal with the tubes. We just go directly from the vagina using a needle into the ovaries to get eggs. So let's see, I have a little video on that. Let's see if this thing lights up. Okay, so what are we seeing? This woman, now, just to tell you, this woman has above average number of eggs. We don't always see this many. We'd like to. And so here's the needle. See, it's sucking out the fluid. So all these are little fluid-filled cysts, and inside is an egg that's just floating around. Microscopic, we cannot see the egg. But what we do is we get this fluid. It goes into a test tube near the surgeon. And then that test tube goes to the laboratory and we dump it in a dish and we sift through the fluid and we find the eggs. So each one of those should have an egg in it. They don't always. Like if we see 20, maybe we get 15 eggs. All right, so now we get an egg. We have to fertilize it. There's two ways to fertilize eggs. One is to let the sperm swim in, and the other is to inject the egg. If there's a lot of sperm available, if the man has a good sperm count, we can just let the sperm swim in. A lot of sperm, right? Not just one. If the sperm count is low, we need to pick up a sperm and shoot it into inject the egg. So let's see what we have here. Another video. Okay, so I'm going to pause this for a second. What we see here, this is the egg. And all this hairy, fluffy stuff are cells, ovarian cells. So when we take out the egg, it has a clump of cells around it that are from the ovary. But doesn't matter. The sperm can just swim through. These are sperm. And you might see some of them moving towards the egg. You can kind of see on the surface, there's some sperm here.
One will get in.
And by some miracle, despite tons of them trying to get in, only one does, usually, sometimes two, but usually we can't use one when it gets more than one. So they have the power and the direction to swim through the cells to swim right into the egg. And so that's how we fertilize them in the lab. And then if we need to do something special, we can inject the egg. And here you go. This is really cool. All right, so here's an egg. Now, just to pause this for a sec. So all those cells have been removed. We manually remove those cells, those ovarian cells, because they make it very hard to see the egg. And when we're going to inject, we need to see everything. So we take away those cells. And now we can see this beautiful egg that's been ovulated. What's this? This is very interesting. This is a shell. Most people don't know that humans, just like chickens, have shells too. We pop from our shell, we hatch. Everyone on this call has hatched. So congratulations. This is a needle with the sperm at the tip, and it's going to push into the egg. And what's really interesting, at least, even though it looks like this needle is in the egg, it's not in yet, because this membrane of the egg really kind of pushes in. So you'll see the needle's going to just turn a little bit more to make sure it's in the right place. When we started learning about ICSI, we started pushing sperm in, and we couldn't figure out why they weren't fertilizing the eggs. And a lot of times it's just because we weren't getting them into the eggs. So we watch a little more. That's it. Now it's in. They're sucking back some of the fluid. Now the sperm's going to get injected in. Now it's actually in here, and that's it. Now that egg is going to start to be fertilized. So that's something called ICSI. So after fertilization, this is what you get. Here, this is the genetic material, probably of the sperm. This is genetic material of the egg, and there's going to start to come together. And here's an egg that's divided, 2 cells, 4 cells. It doesn't always go 2, 4. Sometimes it goes 2, 3, 4. Then there's 8 cells. And then it kind of becomes what's called a morula. Here, the cells are not as distinct. Everything kind of comes together. So let's look at that. This is now a blastocyst. This is 5 days after fertilization. So I'll show some things to you. This, if you look carefully, there's a clump of cells here. This is what we call the inner cell mass. These are the cells that are going to form the baby. These are the cells that are going to form the placenta. So you may see there's a lot more placenta cells than there are embryo cells, fetal cells, at least initially. Because those are the important cells that need to hold on to the uterus to communicate with the uterus and support the fetus, okay? Here's just some other pictures. Now, that blastocyst I just showed you, that was similar to this one, not the same. But I want to point out to you that not every blastocyst is the same. There are varying qualities. Like this is has a very visible inner cell mass. It's got a lot of cells here where the placenta will be. And just to compare this, right, this has a very tiny inner cell mass. There's very few placental cells. And then there's just in between, this one, not quite as many cells. So there is variation in the way embryos grow. So let's look at what it looks like in our lab.
One day after fertilization, the embryos are observed.
All right, so here's this fertilized. This is already fertilized.
Has occurred, a single cell
Here's the
is
shell.
containing 2 nuclei, male and female. Two days after puncture,
Okay, so
the
this is a
embryo
video.
divides itself
So here you
into
now see 2 cells.
with 1 nucleus per cell, which in turn starts to divide into an embryo of 4 cells if its development is
It's
optimal.
amazing how they just appear, right? These are 4 cells now.
3 days following puncture, the
And
embryo
now
starts to divide
dividing
and
again.
consists of 8 cells if its development is optimal.
All right, good.
On day 4, the embryo divides a number of times, becoming a morula.
Now it's more cells here. And now you'll
This
see
is when it
here,
begins to become
you kind of lose the distinction between cells. For some reason, they're kind of all getting together and all communicating. And then you'll see forming
on day 5, the embryo contains more than 100
a blastocyst.
cells.
This is a
In the
very,
center,
so here we
there
go.
is a
Here's the inner cell mass here. And this is fluid. So that's why they call it blastocyst. It's fluid. So this is what happens on day 5. Now, we'll talk about this later, but this is when we do, if in some cases, we do a biopsy of this embryo. We want to see what the genetic component is. So we take some cells off. And this is when we do it. When the embryo is nice and expanded. When we do that biopsy, we don't take cells from here. We take cells from here because we don't want to take the fetal cells. All right, we already saw that. Now let's put the embryo in. Okay, that's easy. That doesn't require anesthesia, doesn't require a needle. We just take a soft catheter, we slip it through the vagina into the uterus, and we just basically just squirt it in. We just squirt it in. There's a video of that.
The embryos selected for transfer are loaded into a special embryo transfer.
So we take the
catheter.
embryo
The
from the
vagina
dish,
is
we put it in the
opened using a
catheter, we use a speculum.
The embryo transfer
This is an
catheter
ultrasound,
is
so we do it under
introduced
ultrasound.
and
So you see here, it's very quick. You see that little line there? There you go. Just squirt it right in. All we do.
From the base of the uterus. The embryos are introduced into the uterine cavity. The catheter is then carefully removed.
Very simple. We try to be atraumatic. We don't want to disturb anything, but it's very simple. Usually no anesthesia, nothing. All right, we saw that. All right, so now let's talk about twins, okay? Twins are commonly produced after in vitro fertilization, but they shouldn't be. Back in the day, we were just desperate to get people pregnant. Our pregnancy rates were 10%. So we were putting embryos, 4 or 5 embryos into our patients in the hope that they would get 1 to stick. And at that time, sometimes we got more than 1 to stick. We would get 2 to stick or 3 to stick or 4 to stick, which actually was catastrophic. We, the doctors, we were very proud of ourselves. We're like, oh, this is amazing. Yeah, she's got triplets. That's amazing. She went from nothing to 3, but triplets is so complicated, so traumatic, that really was a mistake, because some of those kids miscarried. Some of those kids were born prematurely with significant birth defects. And, we really thought we were helping, but we could have done a better job. So as time has gone on, most infertility centers have been reducing the number of embryos that they put in to reduce the chance of this. But not all clinics do that, and they really should. So, your success rate can be proportional to the number of embryos that you come in. So if you're a clinic and your success rate is marginal, maybe your lab isn't as good or you don't pay attention or whatever, one way to get around that is just put more embryos in. But that's a burden to the patient that you don't have to deal with. So that's not really fair. Patients will choose their pregnancy, their clinic, right? In the United States, patients will choose where to go based on the success rates of the clinic. Success rates are published. And so one way to up your success rates to keep bringing patients in is to is to do that, is to increase your odds by putting more embryos in. Not a good idea. The problem with twins is that, just forgetting about triplets now, just talking about twins. The problem with twins is they deliver early. So you can see this graph here. This is the average delivery time of singletons. It's about 40 weeks. And the average twin is about 37 weeks. So you're already reducing your gestational age, which is very important. The longer a baby is in the womb, the better it's going to be, not only after birth, but for the rest of its life. So we try to keep those kids for as long as possible. So this part of the graph shows all of the extra deliveries that occur early because of twinning, right? Here's the single peak. So some of these twins deliver, not every singleton delivers early. Delivers late. Some singletons do normally deliver early. And that's kind of covered in this part. But this part is all of the excess deliveries premature that occur as a result of having twins. Okay, we spoke about that. Now, little things, not little, important. Twins have a 7 times increased rate of cerebral palsy. So that's a very big deal. Cerebral palsy is very obviously significant. Also, just sociologically, the divorce rate is higher in people who have twins. It's just too much. It's just a lot. It really is. Now, we all know twins. I might be speaking to some twins. I don't mean to disrespect twins. But reducing the number of twins that we produce, I think, could be of benefit to a lot of people. So this just shows you the percentage of cases we do where we're putting more than one embryo, when we're putting only one. So back in 2009, 95% of the time we put in 2 or more embryos. And slowly we got it. Even in 2010, it was worse, right? And then all of a sudden we woke up and we said, all right, we should really be putting in 1. So we went to, and there was a lot of controversy about this. A lot of other clinics would say, what are you doing? You're only putting in 1. And patients got very nervous, right? If the conventional wisdom is put in more embryos, and you come to me and I say, I'm only putting 1 in, it makes patients nervous. But the fact is we're getting better at IVF. We can maintain an excellent pregnancy rate and still put in 1. So now over 98% of our transfers are single embryo transfers. All right, we're going to shift gears a little bit. We're going to talk about egg freezing, right? Egg freezing, I call it the infertility's whole evasive holy grail, because for a long time, people have had ideas about egg freezing for decades, but we couldn't quite figure it out. So it wasn't available until recently. And even now, egg freezing is good. We do a lot of egg freezing, but egg freezing isn't quite as good as freezing an embryo. In other words, fertilizing it first. But we still do a lot of egg freezing, and for many people, it's successful. Why do people freeze their eggs? Well, they freeze their eggs. Maybe they're going to get chemotherapy for cancer, and that will kill their ovaries. It'll kill the eggs in their ovaries. So they want to freeze their eggs quickly, and they don't have a partner. So it's not like they can make embryos, and they don't want to use donor sperm. Some women are going to have their ovaries removed soon, maybe for the same reasons. Most of the egg freezing we do is what we call elective. A woman comes in, she's at a certain age, she doesn't have a partner, she's worried about getting older, she wants to freeze her eggs to preserve them for later. That's really the vast majority of what we do. And most of these patients, they don't have a partner, they don't want to use donor sperm, so they just want to freeze their eggs. Egg freezing is empowering, right? A woman can save her fertility for down the road. The problem is it's no guarantee. Not every egg freeze cycle works. Most eggs don't make babies. So just because a woman has 20 eggs in the freezer, it doesn't mean she's even going to have 1 child. She should with 20 eggs, depending on her age, but she may not. So that brings up ethical issues too. All right, we talked about the decrease in egg number, right? This is, we talked about that. Now, this is in vitro fertilization, just talking about not getting pregnant on your IVF success rate. So here you go. Here's in vitro fertilization success rate with age. See how it really shoots down as a woman ages? So someone might say, look, I'd rather freeze my eggs at 34 and have some sort of pregnancy rate that's in this zone than freeze my eggs then when I'm 40 and have a pregnancy rate that's in this zone because there are fewer eggs and the quality is lower. I think I'll skip this part. I mean, that's the thing about freezing. It's the hard part is getting rid of the liquid in the egg, the water. So we replace the water with other substances and we get to freeze the eggs. All right, so that's egg freezing. There's some controversy about egg freezing, like what age should we allow a woman to freeze her eggs? If someone comes in, she's 25 years of age, and she has the money, and she wants to freeze her eggs, should we let her do that? I try to talk my patients who are 25 years of age out of it, because their fertility really isn't going to change till they're maybe 32, 33, and a lot could happen in those years. There's really no change in a woman's fertility between, as long as we check her baseline, make sure she has eggs. But if she has eggs at 25, she's going to have eggs at 30. So maybe those patients shouldn't undergo egg freezing, or they should at least postpone it or wait. And then should you just tell people that egg freezing is kind of a guarantee? I think a lot of egg freezing programs kind of make that claim. And a lot of egg freezing programs don't talk about side effects and complications, and they don't talk about the chance of having a baby. You know, a woman who's 35 years of age needs about 15 eggs to make one baby, 15. And a lot of women doing egg freezing don't understand that. And they might freeze 10 eggs and just think, okay, that's great, I'm done. Or even if they freeze 20 eggs, they might think that's 5 kids, but it's not. I mean, women are lucky. I mean, it's the bell-shaped curve. You could have women who freeze 7 eggs and get 2 kids out of it. Or you could have women who freeze 30 eggs and have no kids out of it. So because there's lots of steps. The egg has to fertilize, then it has to grow into those pictures that I showed you, but not every egg does that. So, and then even if you get a beautiful embryo and put it in, it doesn't necessarily make a baby. So those are some of the ethical issues that surround, egg freezing. All right, so let's talk now different. We're going to talk about the genetic testing of an embryo. I think I showed you like where we take this biopsy, but let's talk about that a little bit more. So, okay, we've seen it before. This is pregnancy rate as a woman ages, but what else is happening? As she gets pregnant, the miscarriage rate is increasing. Because as a woman ages, she's more likely to have chromosomal abnormalities that lead to miscarriage. Like we're all familiar with Down syndrome, right? That's an extra chromosome 21. But at the embryo stage, any of the chromosomes can be missing or extra. So those lead to just a non-pregnancy or they lead to a miscarriage. So by weeding those out, by separating those out, we can increase a woman's efficiency. We can increase her chance of becoming pregnant. We can greatly reduce her chance of having a miscarriage. Here's a chromosome panel. You just need to know that we have 2 pairs of everything. There's 23, including the X and the Y. And if there's an extra one or a missing one, most of the time that's either a non-pregnancy or a miscarriage. Sometimes it's a baby, primarily in the case of Down syndrome. That's chromosome 21 here. There'd be an extra one here. Okay, we talked about that. So the terms we use are ploidy, euploidy, and aneuploidy. Euploidy means the chromosome is normal. There's 23 pairs leading to 46, either a boy or a girl. And aneuploidy means there's either something missing or something extra. It could be 47 with an extra one. It could be 45 with a missing one. Or sometimes they're missing 2 or 3, or et cetera. These are the ones that cause problems. All right, we don't need this. We don't need this. We put it in a machine. Like we used to do counts, we just put it in a machine. It tells us what the embryo is like. And here's a readout. So this embryo is 46XX. So each one of these boxes is a chromosome. 1, 2, 3 is measuring a chromosome. And as long as these readouts are even, then we know there's 2 copies. That's what you want. And the reason it's X, they have 2 copies of X, so it's a girl. This one is showing that there's a bump here. And this one, therefore, is trisomy, has an extra chromosome on 21. This one, there's a trough, there's a low. This one's not getting enough information. There's not enough, there's a missing chromosome, number 6. Okay, Now, a lot of embryos are abnormal. Most embryos are abnormal. Most embryos that we get in our lab are chromosomally abnormal. They're aneuploid. They're missing or extra chromosomes. Even from a woman who I consider young, 34 years of age, 40% of her embryos are abnormal. 40%, 60%. Actually, sometimes it's even more than that. From a 40-year-old woman, 90% of her embryos are abnormal. So that's why it's really hard for somebody who's 40, even if she's ovulating, to get pregnant, because she's making a lot of abnormal embryos. So with in vitro and embryo testing, we can help them with these things. So let's see, this is us. Let's see if we get a video here. All right, so here's an embryo. Here, this embryo is actually hatching through the shell. I mentioned we hatched, that's why it looks like a dumbbell. Here are the cells that are going to become the fetus. So we're going to stay away from those. And we're going to take some of these cells off and send them to this analysis, this machine thing. So here you go. They're going to increase the magnification. And we're going to use a laser to cut away some of these cells. You'll see this red thing here is where a laser is going to be. So you'll see some blasts. You may not see a blast, but what they're pulsing the laser. So you didn't see the blast, but the laser just, and it helps the cells separate. Then we send those cells to another. This is what the embryo looks like when we're done. Looks like it's been, and those everything just normalizes after that. Okay. Now, again, just showing you how the euploidy, right, normal embryo changes with age. A lot. Now, here's another graph. So stick with me on this one. Here's that graph I pretty much showed you that shows, but it's different. This is pregnancy rate, all right? So if you look at pregnancy rates by age, here's the age down here. Look at the pregnancy rate go down with age. Why is it going down? Because the number of abnormal embryos goes up. The number of normal embryos goes down. So we put an embryo in, it's not normal. It either just doesn't grow usually or causes a miscarriage. But what's going on here is that as age increases, the pregnancy rate remains high when we test the embryos. So if we put an embryo in that's normal, age goes away. It doesn't matter if that woman is 30, 20, or 40. Her pregnancy rate is the same. Now, the only trick to this is that it's harder for an older woman to get a normal embryo because so many are abnormal. But so the big if is if she gets a normal embryo, then her odds of having a baby are the same as anybody else, even someone who's much, much younger. So that's very important because it tells us, first of all, why women have trouble having pregnant, like we're going back to that graph with all those lines and showing a decrease with age among the Hutterites and the Mennonites. The reason is that the embryos they're producing are abnormal. Some women, when they do an IVF cycle, they don't get any normal embryos. So we see that here, 73% of women in their 40s don't get any normal embryos when they do a full-blown IVF cycle. At age 35 to 40, it's a little bit, they're more likely to get a normal embryo. All right, so here's a big topic and has ethical implication, mosaicism. So what is mosaic embryo? A mosaic embryo is an embryo that has normal cells and it also has some abnormal cells all mixed in at the same time. So part of the problem is when we do a biopsy, we're only biopsying one section. We're not doing a biopsy of the entire embryo. Although studies have shown since that if you do a biopsy, you're getting pretty close to what the rest of the embryo shows. But getting back to mosaicism, what we're finding is that a lot of mosaic embryos make babies, normal babies. So maybe we're all mosaic anyway. Maybe mosaicism is part of just the normal life cycle. And to have a few cells that are abnormal, maybe they slow down and the normal cells grow quicker and take over the embryo. So we're finding about that. This is a problem that we're dealing with. Now, does every egg make a baby? No. When we get eggs, they have to be mature. This whole thing about 2 weeks on drug is taking an egg that's not mature and maturing it. So the egg has to be mature. Not every egg is. Only 70% of eggs fertilize. Not every egg fertilizes. Of the eggs that fertilize, only 50 to 60% of them grow into these nice looking embryos that I showed you. So we're losing every step of the way. And then depending on a woman's age, 10 to 50% are tested normal. And of a normal embryo, only about 60% of normal embryos make babies. So lots of loss. So now it doesn't mean, if you saw this, you would say, God, IVF, it's impossible for it to work. The fact of the matter is IVF works great, but not maybe on the first try, maybe not for everybody, but in general, it's fantastic. Okay, this is some other stuff that, all right, let's see. All right, and if we have a few more minutes. Let's talk about egg donation. Taking an egg from one woman and giving it to another woman. It's kind of like sperm donation, right? But egg donation is a little bit more complicated because for a woman to give her eggs, she has to undergo a fertility cycle. She has to take fertility injections into her body. She has to have office visits. She has to have anesthesia. She has to have a minor operation for the needle to go into her ovaries. So it's not quite as easy, right, as giving sperm. Donors are recruited. Most practices advertise for donors. There's ethical issues. In some countries, egg donation you're not allowed to recruit. In some countries, egg donors are not allowed to get paid. In the United States, we can pay our egg donors. I mean, it's basically for their time and effort, but it is financial payment. Usually the minimum is about $7,000. Standard is about $10,000, but it could go up to 20 or more. Typical ad, very benign, but the donors undergo screening. It's part of they have to do this to donate their eggs. They have to do medical screening. And there are ethical issues associated with medical screening. Because let's say you're a young, healthy woman and you go to a doctor's office and you go in there and they say, oh, guess what? You need heart surgery. We find things at times. We tell them things genetically about themselves that they may never really need to know. And that's maybe not the best thing. I don't think it's a bad thing, but for some people telling them, oh, by the way, you're a carrier for cystic fibrosis or something, maybe that's not information that they want. They might do an egg donor cycle. They might give their eggs and find out they only make three eggs. And now we tell them, listen, you got to be careful. You're probably infertile or less fertile, or you're going to go into menopause earlier than somebody else. Did they need to know that? I mean, if they didn't donate their eggs, they would have never known. And maybe it didn't matter. But now they have the burden of information. So that's an ethical dilemma among many, genetic counselors. There are side effects of the medicines. We didn't talk about that before, but there's, cramping, bloating. Maybe they have to stay in bed. Some women have to get hospitalized after their IVF cycle. It's rare, but we've had to give blood transfusion. Sometimes women get ovaries, they get very big, they overstimulate. We have to hospitalize them. Their ovaries twist, they need surgery. Very rare, but it happens. And there's psychological aspects to donating your egg. There could be short and long-term emotional aspects. There might be negative information, like I said. And then there might be issues related to just thinking about those eggs through time and wanting, related to child and parent contact. Maybe a donor says to us, yes, I want to be contacted. Maybe that child never wants to contact you. Maybe it's the opposite. Maybe the child wants to contact you, but you're not available. You don't want to be contacted. Those are all things we discuss with all the time. Compensation we talked about. And then we have to tell the donors, hey, donors need to be informed on what's happening to their eggs once we get them, right? Who knows what's happening? We know, but they may not know. So we might give them to 2 people instead of this donor might make so many eggs, we might give them to 2 people. Donor needs to know that up front. We might freeze her eggs for later use. We might get embryos and freeze them. We might be testing those embryos for genetic problems. Those embryos might go to one person, and 10 years from now, those embryos, she might say, I don't want them anymore, and I'm going to give them to somebody else. That could happen. Doesn't happen often, but it might. So we have to tell the donor that this might happen. We might transfer two, which we don't really do that much anymore. And she might give her eggs to a couple that never uses them. This sometimes happens. Maybe they get a medical problem. Maybe they change their mind. Maybe those embryos are just sitting in the freezer doing nothing. You know, maybe they get discarded. Who knows? So these are all things we have to talk to our people about. I'm just going to check my schedule quick, see where I am as far as time, see what my next task is. All right, I am going to stop now, and I am going to entertain any discussion that anyone would like to have.
I have a question for you, Dr. Licciardi.
Sure.
Does egg freezing affect your ability to conceive naturally?
So we do not believe it does. So we're going to go back to this whole thing about starting with 500,000 eggs. So every month, women are losing about 1,000 eggs if you do the math, which sounds, again, I'm sorry, I have to apologize for even saying it. Sounds so terrible. But we just feel we're getting a bunch of those eggs anyway. So if a woman 1,000 and we get 20, it hasn't been shown that women have infertility issues or going to menopause earlier because they've done an egg donation cycle.
Thank you.
What else? Anything?
I just have one question regarding creating embryos, or two. One, can you choose the number of embryos that are created? And number two, if you insert one embryo, can it split to become two?
The answer is yes to both questions. So we have some patients, for whatever reason, say, let's say they make 20 eggs, and they say, you know what, Dr. Licciardi, I'm not comfortable with making embryos that I may not use later or whatever. Can you only fertilize 4, say, and I'll freeze the rest as eggs? And we do that. And then about 2% of the time, an embryo, when we put in one, we have twins. The embryo splits and there are two. Now, just to tell you, that's not a great outcome. Most of the time it works out, but in many cases that embryo is not, that's a more complicated pregnancy because they may share a placenta, they may share, so it's a much more dangerous pregnancy. An identical twin is a much more dangerous pregnancy than an embryo, than a twin pregnancy that's created by two eggs.
All right, thank you.
I had a question, if that's okay. You said about embryos sitting in a freezer. I was just wondering, what is their ethical policies on how long they're kept, and you know, if they're decided to not be kept, like then what happens to them?
So we have no, there's no legal policy. I think in the UK, there's a limit. So patients pay for storage. So that's kind of the indicator that they still want their embryos. They pay $1,000 a year to keep them stored. And then if they stop paying, then we contact them. We say, listen, that's fine. Do you want us to destroy your embryos, or do you want to move somewhere or whatever? And if we don't hear from them, our policy is to destroy the embryos. But frankly, we usually hear from them. We might just have a couple people that we haven't heard from, and it's not worth it. It's not worth it to us to destroy them, because then what if they really, whatever. So that's our policy. Yeah.
I have a question about egg donation, just from the perspective of the person who's donating their own eggs. Are they supposed to be in contact with the prospective parents, or do they really get a decision on who uses their eggs, or is that more of decision based on whatever agency?
They may come in and say, look, I only want my eggs going to a Jewish recipient or a certain ethnic background. We've had that. Usually they don't, but sometimes they could. As far as contact goes, there's kind of the institutional policies, and then there's the private policies. So if I find an egg donor online and I meet her at a cafe and she become best friends, then whatever we do among ourselves is between us. But in the institutional processes, we delineate. We say, listen, We are not going to put anyone in touch with anybody. However, when the donor is 18 or when the baby is 18 and she wants to maybe find out who her donor is, she can contact us and maybe we'll try to find, we don't keep track of the donors as years go by, but we might still have her, once we have her name and there's, with the internet, we should be able to find her. And we could ask her if she would like to be contacted, but we ask that up front. If she wants to be contacted. If she said, I don't want to be contacted, we don't contact. She could always contact us later. She could change her mind and call me up and say, Dr. Licciardi, I donated my eggs 20 years ago. And if any, young men or women come in that want to find me, I'd be very happy to speak to them. But unless she tells us specifically, we don't do that. Now, with the internet, who knows what people can find, right? That's why we used to always say, oh, we do everything possible to keep this donation anonymous. Now we say, there's no way we can keep this anonymous. So you got to decide if you want to do it or not. What else?
Just a question I would like. If you have a request from a couple or a person with genetic anomaly, which ask for in vitro fertilization and an enhancement for helping them to have babies. I presume that the person already is known to have a genetic anomaly or even a Down syndrome, something like that. And because of this anomaly, they cannot have a normal pregnancy. If you consider ethically to help them or not.
Yes. So just to make it clear, because I didn't make it clear, when I mentioned all this embryo testing that we do, that's actually not for specific genetic diseases. That's for big pieces of DNA that are missing or extra. But we also can test for specific things like sickle cell, cystic fibrosis, et cetera. Now, in the case of a woman who's infertile because of her genetic disease, there aren't too many of those, but an example is Turner syndrome. These women have no eggs and they want to become pregnant. So we might take an egg from a donor and let her do it that way. Or let's say a woman is sick with cystic fibrosis. We have patients who are like that. They want to get pregnant, they want to carry, but they don't want to have a child with cystic fibrosis. So we'll test the embryos first, but those diseases really don't make them infertile. They're still fertile. So that's how we handle those things.
Okay, thank you.
Sure. All right. Anything?
Hello.
Yes, go on.
Yes. Thank you. I just wanted to find out with the legal rights, because you did speak about a freezing of the egg, but you also spoke about a freezing of the embryo. And so when you do contact them annually, who do you specifically contact in particular with the embryo? Is it the father, the mother? Do you contact both of them to find out if you should go ahead and continue freezing the embryo? I assume with the egg, it's a lot easier. You just contact the female. But in cases where it's the embryo and it's already fertilized, in that case, what are the legal permissions?
So if we're just getting information, we could just contact the female partner. But if there's a decision that needs to be made, then we need both parties to agree. We cannot just thaw and discard an embryo from a married couple based on the request of one of the parties. We cannot do that. Obviously we have people get divorced, so we have embryos and we need both of them. And if we can't get both of them, we just leave them there. Or they'll go through a lawyer or a judge and we'll get a letter from them saying what to do.
Thank you.
You're welcome.
Hi, I have a question.
Sure.
When you were talking about embryos, was it the term implanting embryos? It reminded me of Octomom, who had embryos implanted and ended up with 8 babies. And I just found out that she actually requested all of those embryos. So I guess this is kind of a question, kind of some food for thought, but do you think it was ethical for the doctors to allow that?
Absolutely not. It just wasn't. There was no reason to do that. This was, I just can't explain it, why anything like that would ever happen. I'm there. I can't comment at all, but absolutely breached many ethical principles. Right? It's the right of the woman, right? But it's also the right of the children. Children might not have a right. They probably have a right not to share a uterus with 7 other people. But that's, I suppose, debatable also. Thank God they all made it through some way, shape, or form.
Dr. Licciardi, do you have time for one more question?
I do. Thank you.
All right, Adam, go ahead. You'll be the last question for the day.
Just one quick thing. Can you ever pre-screen eggs or sperm for certain genetic conditions? For instance, could you ever see if before fertilization, if there was Down syndrome or even another genetic condition?
Adam, I want you to work on this. You will become the next Bezos if you can figure this out, because we can test an egg. So I showed you an egg. Imagine the egg, and on the top of the egg is a little tiny cell. So that's part of the cell division of the egg, and that little cell gets kind of pushed away. But in that cell is a genetic mirror of what's in the egg. And if we test that little cell called a polar body, we can find out a lot of things about the genetics of the egg. The problem is, under today's testing capabilities, it's about 85% effective. It gives us inaccurate information 85% of the time. And 85% just doesn't cut it. It's just in the medical world, if you want to have a reliable test, you need a test that's like 98%. Otherwise, there's too many false positives, too many false negatives, just doesn't work. With sperm, you have to kill the sperm to get the genetic information. So we can't just pick up a sperm, find out what's in it, and use that same sperm to then inject into an egg. But it's a great question. Believe me, it's start working on it.
Thank you.
All right, guys. This was tremendous honor to be in front of all such amazing people. It's an honor to get asked to speak. And I want to thank everybody, my good friends and my new friends. And again, just contact me if you need anything at all.